Welcome back. I'm an emergency doctor actively working at the emergency department of my hospital. In this Doctor's Corner series, we'll dive into lesser-known approaches and hidden strategies to help the people with critical illnesses. You can subscribe if you want to learn the latest news and healthy solutions about your health. Good day, everyone. Today, focus your attention on one of the most misunderstood battles in health, alcohol addiction, and one of the most powerful tools for changing its direction, goal setting. Do not think of goal setting as a motivational poster. Do not reduce it to "I will stop drinking." That is too vague. That is too fragile. Instead, see goal setting as a clinical instrument. See it as a way to turn a foggy desire into a measurable plan, a plan into behavior, and behavior into recovery. Why does this matter? Because alcohol use disorder is not simply bad discipline. It is a medical condition involving craving, reward learning, withdrawal, stress reactivity, habit loops, social cues, and impaired control. The National Institute on Alcohol Abuse and Alcoholism describes alcohol use disorder as impaired ability to stop or control alcohol use despite negative social, occupational, or health consequences, and modern treatment includes behavioral therapies, medications, mutual support, and individualized recovery planning. So ask yourself, why would a person continue drinking after losing trust, sleep, health, money, peace, or family connection? The answer is not simple weakness. The answer is that the brain has learned alcohol as relief, reward, escape, identity, ritual, and sometimes survival. Now ask the next question. How do we teach the brain a different route? Start with goals, not grand speeches, not shame, not threats. Start with goals that are specific enough to guide the body when emotion is loud. Start with goals that can survive Friday night, loneliness, payday, grief, celebration, and boredom. Start with goals that tell the person exactly what to do when the craving arrives. First, understand why goal setting works. The addicted brain often lives in the immediate moment. Drink now, feel better now, silence discomfort now. Goal setting pulls the mind forward. It creates a bridge between the present craving and the future self. Why is that important? Because craving narrows vision. It makes tomorrow feel unreal. A written goal makes tomorrow visible again. Tell the person, write the goal down. Speak it out loud, make it concrete. Do not say, "I need to drink less." Say, "For the next 7 days, I will not drink before 8 p.m. I will keep no alcohol at home, and I will call my support person if I have an urge above 6 out of 10. Or say, "For the next 30 days, I will remain abstinent, attend 3 support meetings per week, and meet my clinician every Tuesday." Why does specificity matter? Because the brain cannot follow a blur. It follows cues. It follows instructions. It follows rehearsed sequences. Medical and behavioral literature repeatedly shows that treatment for alcohol use disorder is stronger when it includes structured behavioral work, motivational interviewing, cognitive behavioral therapy, relapse prevention, feedback, planning, and review. A meta-review of evidence-supported psychological interventions found that strategies such as assessment, personalized feedback, goal setting, homework review, motivational interviewing, and problem solving appear commonly across effective alcohol interventions. So give this command clearly. Do not set a goal only about alcohol. Set a goal about the moment before alcohol. Why? Because relapse does not begin with the first drink. It often begins earlier. Skipping breakfast, hiding stress, carrying resentment, passing the liquor store, texting the drinking friend, keeping cash, refusing sleep, saying, "I'm fine," when the nervous system is not fine. How do we use goal setting here? Build pre-drink goals. For example, after work, I will drive home using the route that avoids the bar. When I feel anger in my chest, I will walk for 10 minutes before making any decision. If I am offered a drink, I will say, "Not today, I'm taking care of my health." If I feel lonely after 9 p.m, I will call someone before I isolate. This is where goal setting becomes more than intention. It becomes architecture. There is a powerful planning method in behavioral science called implementation intention. In plain language, it means, if this happens, then I will do that. Research on alcohol consumption has found that forming these if-then plans can reduce weekly alcohol intake and heavy episodic drinking. Ask the audience, why does if-then planning work so well? Because it removes negotiation. When the cue appears, the response is already chosen. The person does not need to invent wisdom while craving is active. The plan is waiting. Say this directly to anyone struggling. Do not wait until the craving is at full volume. Prepare your response while your mind is clear. Put it in your phone, tape it near the door, share it with someone safe, rehearse it like a fire drill. Now, let us go deeper. Alcohol addiction often damages confidence. A person may say, I have failed too many times, but goal setting can rebuild self-efficacy in small doses. How? By creating wins that are small enough to complete and meaningful enough to matter. Do not begin with perfection if perfection has become a weapon. Begin with proof. One sober morning is proof. One honest conversation is proof. One medical appointment is proof. One craving survived without drinking is proof. One weekend planned in advance is proof. These are not tiny things. These are neurological lessons. Why? Because the brain changes through repetition. Every time a person meets a goal, even a modest one, the brain receives new evidence. I can act differently. That evidence weakens hopelessness. But be careful. Goals must be medically safe. If a person has been drinking heavily every day, especially with morning drinking, tremors, seizures, confusion, hallucinations, or previous severe withdrawal, do not command them to stop suddenly without medical guidance. Say this firmly, get assessed, speak to a clinician, do detox safely if needed. NIAA notes that up to half of people with alcohol use disorder may experience withdrawal symptoms when they stop, and some require medical care and monitoring for potentially dangerous symptoms. This is crucial. Goal setting is not a substitute for medicine, it is a partner to medicine. In fact, approved medications can support recovery goals. Naltrexone can help reduce the urge to drink. Acamprosate can help maintain abstinence by easing some negative symptoms after stopping. Disulfiram discourages drinking by causing unpleasant reactions if alcohol is consumed. These are not moral shortcuts, they are treatment tools. So ask, how do we combine goals with medical treatment? Use the 3-layer goal. Layer 1, body goals. Sleep, hydration, nutrition, medical appointments, medication adherence, exercise, withdrawal safety. Layer 2, behavior goals. Avoid high-risk places, remove alcohol from the home, plan transportation, schedule support, attend therapy, track urges. Layer 3, identity goals. Rebuild trust, become present with family, return to work stability, protect dignity, practice honesty, become someone who does not need alcohol to survive a feeling. Tell the person, do not only ask, how do I stop drinking? Ask, what life am I trying to become available for? That question changes the emotional center of recovery. It shifts the goal from punishment to purpose. Now let us make this highly practical. Use the 24-hour goal. Every morning, ask, what is the drinking risk today? Why is today risky? How will I respond? Who will know my plan? Make the answer short. Today is risky because I get paid. Today is risky because I am alone tonight. Today is risky because I argued with my partner. Today is risky because I feel confident and may test myself. Then give yourself commands. Do not enter the store. Do not keep cash for alcohol. Eat dinner before 7 p.m. Text my support person at 5 p.m. Attend the meeting even if I do not feel like talking. Go to bed before the second wave of craving. Why include confidence as a risk? Because many people relapse not only when they feel broken, but when they feel suddenly safe. They say, I can handle one. That sentence can open a trap door. So set a goal for confidence too. When I feel confident, I will protect the progress, not test it. Next, use the craving clock. Most cravings rise, peak, and fall. They feel permanent, but they are often time limited. So make a goal. delay for 20 minutes. During those 20 minutes, change location, drink water, breathe slowly, call someone, take a shower, walk outside, or eat something. Do not debate the rest of your life. Win the next 20 minutes. Ask, why does delay matter? Because addiction demands immediate obedience. Delay breaks obedience. It creates a space where the prefrontal cortex, the planning part of the brain, can re-enter the room. Then use tracking, not to shame yourself, to study yourself. Command this, record the pattern. What time do cravings appear? What emotion comes first? What person increases risk? What place weakens judgment? What thought gives permission? I deserve it, just tonight. No one will know. I already failed. These thoughts are not facts. They are relapse scripts. How do we fight a script? Write a better one before the scene begins. For example, if I think I already failed, then I will say, a slip is data, not destiny. If I think no one will know, then I will message someone immediately. If I think I deserve a drink, then I will answer, I deserve peace tomorrow morning. This is not soft language. This is cognitive restructuring. It is the practical heart of many behavioral treatments. Now include the family, but do it wisely. Family members, listen carefully. Do not become the police. Become part of the plan. Ask, what goal do you want me to support today? Ask, what should I do if you isolate? Ask, what words help you and what words make you shut down? Do not lecture during craving. Use the agreed plan. SAMHSA describes recovery as a process of change through which people improve health and wellness, live self-directed lives, and strive toward their full potential. It also emphasizes that recovery is person-driven and supported by relationships, respect, hope, and community. That matters because goal setting must not humiliate the person, it must restore agency. Say to the person in recovery, own the goal. Do not borrow someone else's recovery as if it must fit you perfectly. Some people need abstinence as the safest goal. Some begin with harm reduction under clinical guidance. Some need medication. Some need residential treatment. Some need outpatient care, mutual support, trauma therapy, or psychiatric care for depression and anxiety. The correct goal is not the one that sounds impressive. The correct goal is the one that protects life, reduces harm, and can be honestly followed. But remember, for many people with moderate to severe alcohol use disorder, controlled drinking may become a mental negotiation that keeps the addiction alive. So ask with courage, is my goal protecting me, or is it protecting my access to alcohol? That question can be uncomfortable. Ask it anyway. Now design goals using 5 standards. Make the goal specific. Make it measurable. Make it realistic. Make it time-bound. Make it connected to a deeper value. Do not say, I will be better. Say, for the next week, I will attend 2 counselling sessions, remove alcohol from my apartment, and call my brother every evening at 8. Do not say, I will avoid triggers. Say, I will not go to the sports bar after work. I will watch the game at home with alcohol-free drinks and leave my wallet in another room. Do not say, I will work on myself. Say, I will sleep by 10:30 p.m, walk 15 minutes after dinner, and write down 1 craving pattern each night. Why include values? Because goals without values feel like restriction. Goals with values feel like direction. A person is not only quitting alcohol, they are returning to mornings without dread. They are returning to parenting without absence. They are returning to memory, liver health, emotional steadiness, financial repair, sexual health, spiritual clarity, and trust. And yes, the stakes are high. Excessive alcohol use remains a leading preventable cause of death in the United States and is linked with several cancers, heart disease, liver disease, and alcohol use disorder. So do not minimize this, but also do not make it hopeless. Goal setting is beneficial because it makes recovery visible. It is effective because it changes the daily mechanics of behavior. It gives the brain cues, gives the body routines, gives the family a shared language, gives clinicians something to measure, and gives the person proof that change is not just a wish. Let us close with this. If alcohol has been controlling the day, take the day back in pieces. Do not try to defeat the entire future tonight. Set the next clear goal, name the next risk, choose the next response, contact the next person, keep the next appointment, survive the next craving, protect the next morning. Ask yourself, why do I want to recover? How will I act when the old pattern calls me? Who will I let stand beside me? What goal will I complete today? Then move. Do not wait for perfect motivation. Build structure first. Motivation often follows structure. And if you are supporting someone, stand close with wisdom. Encourage treatment. Respect dignity. Celebrate honest effort. Watch for danger. Stay steady. Recovery is not a straight line, but it can have a direction. Goal setting gives that direction a map. Take care of yourselves. Take care of one another, and let's keep growing as one family of learners and healers. See you in the next topic.